Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and anytime. This is Swami, and I recently had a critical care shift at my shop with some excellent teaching points that we have discussed in the past on the podcast and on Rebel, but nice to kind of get all of these things in one place, good reminders of some things that we are taking care of on a daily basis. And I figured I could just go through them as a little bit of a spaced repetition of things that we need to know. The first topic was on recent onset atrial fibrillation, and we got into the discussion about whether the patient in front of us could be safely cardioverted or not. If you have a patient with recent onset atrial fibrillation, they come into you and you're considering rhythm control, you can pursue that if either the patient has been on anticoagulation for a substantial amount of time. That lessens, obviously, the chance that they have formed a clot and makes it safe to cardiovert that person. So if you have a patient who has paroxysmal AFib, they're chronically on anticoagulation, they come in with atrial fibrillation, it would be fine to go ahead and convert that patient back into sinus rhythm. The other situations really depend on time and risk factors. So if the patient isn't on long-standing anticoagulation, but they're presenting under 48 hours, then we have to look at their CHADS VASC score. I'll be honest that even though I talk a lot about atrial fibrillation, it's one of my favorite topics to get into, I don't have the CHADS VASC score memorized. Every time that I have to think about that, I'm going to find an online calculator to run it through and make sure that I am not missing anything. But if the patient comes in under 48 hours and they have a CHADS VASC score under 2 for men and under 3 for women, it is safe to cardiovert that patient. So again, CHADS VASC less than 2 for men, less than 3 for women, under 48 hours from time of onset, go ahead and do that cardioversion. If the patient has a CHADS VASC score greater than or equal to 3, so they're in that higher risk category, then we're going to make the cutoff somewhere around 12 hours. If they have recent onset atrial fibrillation within 12 hours, in that higher risk group, it's probably still safe to cardiovert that person. As far as how to cardiovert them, electricity is clearly the most successful means of doing this. It's about 95-96% effective. If you're going to go with a medication, procainamide has a higher success rate than amiodarone. When we look at time of onset, amiodarone can take up to 12, 16, 24 hours before it really has an effect, whereas procainamide is typically going to work during the infusion time. So during the hour that procainamide is going in, it's going to have an effect, or you're going to know that it's not going to be effective and you're going to have to move over to electrical cardioversion. It does seem that procainamide might increase the efficacy of electricity just slightly, a little bit of a change there. So if you give them procainamide, it doesn't work, you can progress to electricity. Procainamide about 66, 67% effective. Again, electricity well over 90%, somewhere in that 95 to 97% range. The next topic we got into was anaphylaxis. And when we think of anaphylaxis, I think a lot of medications come to mind, but the only one that we should be thinking about immediately is epinephrine. And the important part is to really consider, when do I give epinephrine? And Ruben Strayer has a great little saying: if A, B, or C, give E. If the patient has any compromise of airway, breathing, or circulation, give epinephrine in the setting of anaphylaxis. So in those circumstances, you don't need two different systems to be at play. They've got an airway issue, they have a breathing issue, they have a circulation issue, give epinephrine. The dose of that epi is 0.5 milligrams IM, or if you have an IV, you can give the epi IV somewhere between 5 to 10 mics per minute. You can always start with a bolus dose of 5 to 10 mics and then start 5 to 10 mics IV per minute until the patient's symptoms are improved. The IV route can be really helpful in the patients who have circulatory collapse or they have shock, because that IM epinephrine might not actually be circulating into the central circulation where you want it. Whereas the IV, it's going to be more effective, faster, especially in those hypotensive patients. When we look a little bit more broadly at indications for epinephrine and anaphylaxis, what most of the professional societies recommend is that if the patient has 2 or more organ systems involved, go ahead and give epinephrine. The problem with that is it's not always the same depending on which 2 systems are at play. If the patient has breathing and airway involvement, clearly they need epinephrine, right? A, B, or C, give E. But if the patient has rash and nausea, do they really need epinephrine? Well, maybe they do, but I think we can at least take a little bit more time to think about that. If they have compromise of airway, breathing, or circulation, we need to give epinephrine immediately. If we don't, that can very rapidly progress to a worse circumstance. So getting that epinephrine on board when there's any compromise of airway, breathing, or circulation is desperately important, has to be done immediately. Our next topic was looking a little bit at venous thromboembolic disease and specifically looking at D-dimers. And D-dimer, for a long time, I think was the bane of emergency physicians' existence. You thought about the dimer, you got it, they were always positive, and even though the patient had a low risk, you were working with this dimer. But now we have some other ways of looking at using the dimer to rule out more patients without missing too many PEs. And the two that we kind of talked about was age adjusting your D-dimer and the years criteria. I think both of these can be used pretty liberally. They have really good evidence behind them to back them up. One important thing is to know what kind of D-dimer assay you're using in your hospital. Most places are using FEU as the unit. This one has a typical upper limit of normal of 500. But many places are also using DDUs, and DDU has an upper limit of normal somewhere between 230 and 250, depending on exactly your institution. In terms of age adjusting, we want to know which unit is being used because that's going to guide what that new upper limit of normal is. For FEUs, the more common D-dimer unit, it's age times 10. So if the person is 90, then you have a normal D-dimer with an FEU up to 900. If they're 65, then your top normal is 650. If you're using DDUs, which a number of places that I've worked in do, then it's age times 5. So if they're 90, your upper limit of normal is 450. Again, it's really important to know what the normal ranges are, what units are being used. That's going to change your age adjusting. Years criteria is another approach to ruling out more patients using the dimer without missing many PEs. And for a years criteria, the questions you have to ask is, one, is the patient pregnant or not pregnant? If they're not pregnant, then you can move on. And the three things you're looking for are signs of DVT, hemoptysis, and PE is your most likely diagnosis. If the answer to all three of those questions is no, then you can set your D-dimer threshold at 1,000 if you're using FEUs and 500 if you're using DDUs. So again, you're increasing that threshold for the dimer to still be considered a negative in the low-risk patient. Remember, we're using low-risk patients when we're entering into either age adjustment or the years criteria. And again, the data tells us that these are appropriate measures to use to rule out more patients without missing a lot of PEs. We'll drop some good links in the show notes looking at some of the data behind this. Our final topic was on syncope, and syncope ECGs is something that we have covered way back in Rebel Core Cast 21, but a good one to just keep in the back of our mind of when we get that ECG, what are we looking for? Now, they're the easy things to find. If the patient has a clear ischemic component, if you see ST elevation MI, okay, that's an easy one to pick up for the syncope ECG. Pretty uncommon cause of syncope, but something we have to be tuned into. If they have an AV block, if they have the dysrhythmia, if they have significant bradycardia, all of those are kind of the easier ones to find. What we have to focus on, what they pay us the big bucks to do, is to find the less common things, the ones that are a little bit harder to find. And there are 5 big ones that I think we have to focus on. WPW, so that's going to be your delta wave, your short PR interval, remembering that you don't have to have both. If you just have a short PR interval, that's enough to think about WPW. Number 2 is Brugada. That's got that coved type of formation, especially in the anterior leads. These are really good to look up and kind of get an image in your mind of what it looks like. Having Brugada predisposes the patient to developing ventricular tachydysrhythmia, so really important to pick up. Hypertrophic cardiomyopathy, typically what we're looking for are those deep, very narrow Q waves, usually seen in the lateral leads, but they can be in the anterior leads as well. Abnormalities of the QT interval, both long QT and short QT. We need to be looking for both of those. Again, predisposes to ventricular tachydysrhythmias. And then lastly, arrhythmogenic right ventricular cardiomyopathy. I'll be honest, I have never seen one of these in the wild. I've only seen the ECGs online of these patients. What we're looking for is an epsilon wave, which follows your QRS complex. Again, really good to Google and look at these images to kind of burn it into your mind so you know what you're looking for. So again, those 5 things that we have to be scouring the syncope ECG looking for: WPW, Brugada, hypertrophic cardiomyopathy, prolonged or short QT, and arrhythmogenic right ventricular cardiomyopathy. And that's in addition to the more common things that we're going to find and the easier things to find, like the AV blocks, the dysrhythmias, the bradycardia, and the STEMI pattern. So there are 4 pearls, talking about recent onset atrial fibrillation, anaphylaxis, D-dimers, and syncope ECGs. Just to give a quick summary, remember which patients are safe to cardiovert with recent onset atrial fibrillation if they're on anticoagulation, less than 48 hours with a low-risk CHADS-VAS score, or less than 12 hours with a higher-risk CHADS-VAS score. In anaphylaxis, if the patient has compromise of A, B, or C, give E. Any problems with airway, breathing, or circulation, give epinephrine. Dose is 0.5 milligrams IM, or if you have an IV, you can use that route somewhere between 5 and 10 micrograms intravenous. When you have a low-risk patient for venous thromboembolism and you're going to use your dimer, consider using age adjustment or years criteria. That's going to increase the portion of patients that you rule out for VTE or PE with your dimer without missing a significant number of patients. For age adjustment, if you're using FEUs, it's age times 10 as your upper threshold. If you're age adjusting with DVUs, it's going to be age times 5 as your upper limit. And then lastly, syncope ECGs. The 5 big things that we can't miss are WPW Brugada, hypertrophic cardiomyopathy, prolonged or short QTC, and arrhythmogenic right ventricular cardiomyopathy, in addition to the more typical, easier to find things. That's all for the Rebel Core Content Podcast this week. We'll be back in 2 weeks for another cast. In the meantime, don't forget to pop on over to the site, check out the show notes from this episode, as well as all of the contributions of our fantastic faculty. And until next time, stay safe.